In this video, we talk about the respiratory system. In lab, you'll recall that the respiratory system is made up of both an upper portion and a lower portion. The upper portion of the respiratory system consists of the nasal cavity and the pharynx, which we know as the throat, as well as the oral cavity. So air comes in through the nose, it also comes in through the mouth, and then that air mixes as it enters into the pharynx, or the back of the throat. And then as that pharynx divides, food is directed down the esophagus in the back, and air continues on through the larynx, into the trachea, into the bronchi, into the bronchioles, and eventually into the lungs. So we're going to talk about the physiology of these structures in this lecture. And it's important to know that the muscular system is also involved with breathing, and that's the diaphragm. That's the sheet of skeletal muscle that lies below the lungs. And when it's relaxed and in its resting state, it's upward, it curves upward, and decreases the size of the chest cavity. And another muscle that's important for breathing are the external intercostals. So these muscles lie between the ribs, and when they contract, they pull the ribs up and out. And when the diaphragm contracts, it flattens and moves down and makes the chest cavity, the thoracic cavity, larger in volume. And we'll talk more about that as we get along. But remember that breathing in a 24/7, 365 days a year process is involuntary. We don't have to think about it. So it's part of our brainstem activity. We're going to learn about the medulla and the pons and how they are in charge of setting our respiratory rate. And the respiratory rate for a healthy person at rest is anywhere between 12 and 20 breaths per minute. And that is a number you'll need to know. So make sure you write that down. Normal respiratory rate is between 12 and 20 breaths per minute. So when you look at functions of the respiratory system has a lot of different functions in the body other than just bringing air in. The gas exchange that occurs, oxygen enters the blood and carbon leaves the blood and is exhaled. That's an important, very, very important role of the respiratory system. So it brings fresh oxygen from outside the body into the blood via the alveoli, which are the small air sacs of the lungs. And we have regulation of blood pH because carbon dioxide, as it's produced in our tissues as a result of metabolism, it is converted to an acid called carbonic acid. So the more carbon dioxide we have in our blood, the lower the pH is going to be. And that can be dangerous because we have a very tight control of our blood pH, which should be 7.35 to 7.45, if you recall that from our cardiovascular unit. So it's very important that we not let carbon dioxide build up. And the way our body does that is by simply exhaling carbon dioxide. So as long as the lungs are functioning and there's good exchange at the alveoli, at the lungs with the blood, then we know that carbon dioxide will diffuse out of our blood and into our lungs to be exhaled, and oxygen will diffuse into our blood from the lungs to be fed into the tissues via the cardiovascular system. So this blood pH is tightly linked to carbon dioxide levels. So if someone has bad lungs, for example, emphysema or fluid around the lungs, that carbon dioxide can't diffuse out of the blood into the lungs, and as a result it builds up in the blood and that drops pH, and that can cause what we call acidosis, which is any number less than 7.35 for a blood pH. And that can be very dangerous. People get very lethargic and sleepy, and it's something that we need to correct. Another function of the respiratory system is voice production. We know that the larynx has the vocal cords for making the sound of the voice, and also the nasal cavity helps resonate our voice. If you've ever listened to someone over the phone that has, say, a stuffy nose or a very runny nose, you can tell the difference in their voice based on, the health of the nasal cavity. Olfaction, our sense of smell, is another role that the respiratory system has. So we have sensory receptors for different chemicals that enter into the nasal cavity that stimulate the olfactory nerve and send that to the brain for processing as being a smell that we're familiar with or a smell that is pleasant or not so pleasant. And protection. The respiratory system protects us against infection by having certain features such as cilia and mucus that lines the airways to prevent anything in the air from getting into the lungs and causing infection within the body. So lots of different important functions of the respiratory system. Another thing that we see for protecting us against infection are these macrophages, and these are cells that are found inside the alveoli. These are a type of white blood cell found inside the alveoli that also prevent infection from something that would get inhaled actually into the lungs. But typically, most of our housekeeping is done in the upper airways with the help of mucus and cilia. So to look at the processes of the respiratory system, ventilation is a term that we talk about, just moving air in and out of the lungs. So when people have severe respiratory failure, sometimes we have to put them on a ventilator, which helps with that movement of air in and out of the lungs because the individual is not able to do it on their own because of maybe weak respiratory muscles, or we just have to increase the pressure and concentration of oxygen at such a high amount that only a ventilator can accomplish that movement of air and concentration of oxygen. So then we also have different types of respiration. External respiration is talking about the exchange of air that occurs at the level of the lungs and the blood. And internal respiration is the gas exchange of oxygen and carbon dioxide that occurs between the blood and the tissues. So once those gases get inside the body, we have this gas exchange occurring between the tissues and the blood. And of course, just transporting carbon dioxide and oxygen in the blood, that is part of the role of the cardiovascular system working with the respiratory system. So the respiratory system basically brings the oxygen in to the body and blows the carbon dioxide out of the body. So when we look at how the respiratory system is divided, we have the upper respiratory system and the lower respiratory system. And you can think of, if you've ever had an upper respiratory infection, that's usually something that occurs in the nose where you might have a stuffy or runny nose and a sore throat. But a lower respiratory infection is something like bronchitis, where there's a lot of coughing and congestion in the chest, and it can be really uncomfortable, and those types of infections can sometimes lead to pneumonia, where fluid enters the lungs due to inflammatory processes. So the lower respiratory system starts with the larynx, which is our voice box, and everything below. So when we look at the important structures of the upper respiratory tract, a very important structure is the nose. The function of the nose is to bring air in, so it's a passageway for air. It cleans the air because of mucus and cilia that lines our nasal cavity, so that prevents airborne particles from going further into the respiratory system because the mucus, the particles stick to the mucus, and the cilia sweeps that mucus with the trapped particles toward the back of the throat to be swallowed and sent to the digestive tract. So you'll feel the urge every now and then to swallow, and then that mucus with the trapped debris heads right down the esophagus into the digestive tract, where mucus is a good thing and it helps propel our food, and it doesn't have to be sterile because we know our food isn't sterile. So that mucus with the trapped debris is just sent to the digestive tract, and then it's eventually eliminated from the body. The nasal cavity also humidifies the air. Mucus has a high amount of water, and that helps to provide moisture inside the nasal cavity. And it also warms the air with the help of blood vessels in the nasal cavity that are near the surface. Now, you may know someone, or maybe yourself, that tends to get nosebleeds, and that can happen in the wintertime as the nasal cavity gets a little bit dried out from drier winter cold air that we see here in Wisconsin. And also, if you tend to have blood vessels, more vascular mucous membrane, just more blood vessels near the surface, you might have a greater tendency toward nosebleeds. And children tend to have more nosebleeds than adults just because their nose is a little bit more vascular as we grow, and then things kind of even out as we become adults. We know, again, we talked about olfaction, our sense of smell is an important function of the nasal cavity, and those sinuses, those air spaces that we looked at in the skull. Remember, we talked about the ethmoid sinus and the maxillary sinus. Some of those sinuses, those spaces in the nasal or in the skull, help for resonating our speech and giving our voice a good quality sound. So again, the part of the respiratory tract that really helps prevent infection and from inhaling particles into the lungs is the cilia and the mucus. So mucus, I said, is high in water content. It keeps the air moist, but it also traps debris. And our cilia sweeps that trapped debris in the mucus toward the digestive tract. So that those two things are very, very important features for preventing infection. So it keeps those particles out of the lungs. The larynx is what we know as our voice box. And the larynx contains the vocal cords. We learned about that in lab. And remember, it's covered on the top by an epiglottis. So the epiglottis protects the larynx when we're swallowing food, and it keeps food out of this larynx and out of the trachea and getting down into the lungs. So very important structure, this epiglottis. So the larynx has these plates of cartilage around it. We talked about that in lab. We're not going to talk about that again, but the larynx contains the epiglottis. It contains vocal cords or vocal folds that stretch through the center of the larynx. So if we go down, we can see here on this next slide, you can see the vocal cords here. So we're looking down into the larynx here. So we're looking at a top view into the larynx. And remember, the space between the vocal cords we call the glottis. So the glottis, the vocal cords, those are all important for voice production. It gives us the different pitches of our voice. So when you think about when we talk, women have shorter vocal cords and men have longer vocal cords. So that gives the higher and lower pitch of our voice. And also the glottis, when you think about when you want to talk in a lower voice, you tend to open the glottis. And when we talk in a high-pitched voice, we tend to close the glottis or bring those vocal cords closer together. And when they're completely closed, that's when we bear down and increase abdominal pressure, which happens during childbirth with women or reflexively during a bowel movement. So all those structures, the larynx, the glottis, the nasal cavity, like I said, that gives that resonance to our voice, that's all important for voice production. So getting beyond the larynx then, we have the trachea. The trachea is characterized by the C-shaped cartilage. That C-shaped cartilage helps keep the trachea open at all times, so we have constant breathing and constant open airways for breathing. So this is a nice structure for constant airflow. And at the bottom, remember, we have the carina, which when that's stimulated at the bottom of the trachea, that causes a violent coughing reflex to prevent anything from entering the lungs. Because when we get to the bottom of the trachea, we're pretty much, down to the level of the bronchi, and that's when choking can occur. So we want to prevent that by these sensory receptors in the carina being stimulated if something should touch that, like liquid or food. So this is just a nice view of some cilia here that we find lining the trachea. But cartilage is a big part of our upper airways. The trachea, the larynx, the bronchi, those all contain cartilage to keep our airways open. And we know that at the bottom of the trachea becomes the bronchi and then the lungs. So when we look at the tree starting from the bottom of the trachea down to the lungs, this kind of color-coded what would you describe it? Almost like a cast of the airways. Is pretty cool to look at here. We have the trachea, which is the single passageway, the two bronchi, and then we have secondary bronchi, the first branching of the primary bronchus, and then the tertiary bronchi beyond that, and then it branches 21 more times before we get to the lungs. So there's extensive branching of these airways. So we have what we call the conducting zone, which is the upper airway that is part of the trachea, the bronchi, the bronchioles. There's no gas exchange in the conducting zone. So that's the key feature when we talk about conducting zone. It's looking at the airways, no gas exchange. But the respiratory zone, we do have gas exchange. So the respiratory zone is where the alveoli are located. So part of the respiratory zone are going to be the alveolar duct, the alveolar sac, and then the alveoli themselves. That's the respiratory zone. The conducting zone, again, is just the trachea, the primary, secondary, tertiary bronchi, and the bronchioles. So that's just the passageway, the airways. And there's a lot of mucus and cilia and cartilage in the upper part of the conducting zone. But as we get to the bottom of the conducting zone, to the bronchioles, it's mostly smooth muscle. So again, the respiratory zone is referring to the alveolar duct, the alveolar sac, and the alveoli themselves. So this is where the gas exchange occurs. So it's this final destination for the air that we inhale. So remember that each little tiny sac, well, the whole thing is a sac, but each tiny little circular structure within that sac is called an alveoli. That's how you pronounce it, alveoli. So again, when we look at how the alveoli function, gases diffuse across those walls of simple squamous epithelium. Remember, this is all simple squamous epithelium. So we have the bronchus, which is the main passageway coming from the trachea here. The bronchus serves each lung, and then again it branches and branches until we get to the terminal bronchiole. And the bronchiole only contains smooth muscle. So there's no cartilage in the bronchioles. So if we look here, we can see it a little better. Here's the bronchiole, this red here, this is smooth muscle, and that's the only thing keeping these passages open. So when they constrict, this passageway narrows, and if it narrows, we can't exhale and we can't inhale. And that's what happens in people with asthma, is the bronchioles constrict. That smooth muscle they have an overly reactive airway, causing the smooth muscle to constrict, maybe with pollen or allergies. Sometimes it's exercise that causes constriction of the smooth muscle in these bronchioles, and it leads to poor gas exchange and a wheezing sound. As fluid is squeezed out into the bronchioles, people get kind of a wet sound. They get a wheezy sound when they're having an asthma attack. And that's where having rescue inhalers like albuterol, that relaxes the smooth muscle of the bronchioles and then allows that airflow to pass through again from the alveoli into the upper airways. So smooth muscle is the characteristic structure of a bronchiole. But then again, when we get into the alveoli themselves, there's no more smooth muscle. It's just simple squamous epithelium. So when you look at the respiratory membrane, that's the fused membranes, and they're not fused where they're tightly glued together, but they're very close to one another. We have the wall of the alveoli and the wall of the capillaries that are around the alveoli, and that's where the gas exchange occurs. And this gas exchange occurs by diffusion, just simple diffusion. There's more oxygen in the alveoli, so that diffuses into the blood where there's less oxygen. And there's more carbon dioxide in the blood from the tissues because of metabolism, so that's always going to diffuse out of the blood into the alveoli. So it's just a matter of diffusion of these gases from high concentration to low concentration. And again, the pulmonary capillaries are wrapped around these alveoli, kind of like soccer balls in a mesh bag. So if you think of this, each alveolus like a soccer ball and the capillaries like a mesh bag right around them, that gas exchange is nice and close between the blood and the alveoli, which make up the lungs. So this is called the respiratory membrane. These two membranes close together, allowing for the diffusion of carbon dioxide and oxygen. So when we look at the lungs, they're a little bit different, the left and right lungs. The right lung has 3 lobes, and the bronchus that serves the right lung is a little bit more vertical and it's a little bit wider. So people find that when choking occurs, that is more likely to occur in the right lung compared to the left lung. The left lung has only 2 lobes, so that's these divisions here. And the left lung has 2 lobes, and it has a little notch for the heart to fit, which we call the cardiac notch. So slightly different anatomy of the right and left lung, but same amount of pressure in the lungs, same amount of volume in the lungs. It's just a slight difference in their anatomical makeup. So if the job of the respiratory system is gas exchange, well, it's important that we can bring this air in from the outside where there's lots of oxygen outside the body. We need to get that inside the body. And the 2 major muscles for that, again, are the external intercostals, which are these muscles that lie between the ribs, and the diaphragm. So those 2 muscles work together on an involuntary basis for quiet breathing. So we don't have to think about this. When the external intercostals contract, the ribs move outward. So it makes the chest cavity nice and big and wide, and the volume inside increases when they contract. And when the diaphragm contracts, it moves down. It moves down, and that too provides more volume inside the chest cavity if this curved diaphragm, when it contracts, moves down and away, allowing more volume. And when we have more volume inside the chest cavity, that decreases the pressure inside the chest cavity, and that promotes the flow of air into the chest. So it's important that we understand that we need to contract the muscles first in order to get air to flow. The external intercostals moving the ribs up and out, and the diaphragm moving down, that is going to decrease the volume. It's going to increase the volume. It's going to make it bigger inside the chest cavity, which is going to result in a drop in pressure from the inside the body compared to outside. So there's more pressure outside in the atmosphere, which will cause air to flow in to where there's less pressure inside the chest cavity. So that's Boyle's law. Boyle's law relates pressure and volume, which states that if we increase the volume of a space, we decrease the pressure of the particles inside that space. And if we decrease the volume of a space, we will increase the pressure, because with less volume, there's more contact between particles, and that increases pressure. So ventilation is just the switching back and forth of these muscles, contracting them to increase the volume and decrease the pressure, and air flows in. And then when those pressures are equal, as air fills that space, then the pressures on the outside the body are equal to pressures inside the body. Airflow stops flowing, and then as those muscles relax, then the diaphragm moves back up, the ribs move back in, volume decreases, pressure rises, and air flows out of the lungs. So exhaling is really a passive process with the muscles of the diaphragm and the external intercostal relaxing. So when we look at the anatomy of the lungs, we have 2 membranes that surround the lungs, and they're very important membranes because one membrane covers the lung itself. That's the visceral pleura. You'll remember this maybe from our first week of class when we talk about this. We talked about these different serous membranes in lab. So the visceral pleura lies on the lung, and then it folds over as it gets to the body wall and lines the body wall, and that's called the parietal pleura. So the parietal pleura lines the body wall, and then it becomes the visceral pleura as it comes over and lines the lung itself. So parietal lining the body wall, visceral lining the lung itself. So these membranes fold over one another, and there's fluid between them called pleural fluid, and that acts as a lubricant. So when the lungs are expanding and contracting, they don't cause pain as they rub against the body wall. And these membranes are stuck together by this fluid, which pulls the lungs with the body wall when we inhale, and then they go back inward when we exhale. And that's really, really important because there should be a negative pressure between these two membranes, which keeps the lung expanded. It's called pleural pressure, and it's because of the slight pull in opposite directions of the parietal pleura from the visceral pleura. And that little stretch between those two membranes as they're moving against one another causes that negative pressure. And if we lose that negative pressure, we get lung collapse. And a name for lung collapse is atelectasis. It's kind of a fancy word, but atelectasis is when our lungs collapse. And that can happen spontaneously as air enters into the lungs, say from a broken rib during an accident, from a gunshot wound, from a stabbing, or from surgery. And what we do to repair a lung collapse is we give someone what we call a chest tube. A chest tube is when we put a plastic tube in between the ribs into that space, and we have negative pressure in a small plastic box that is connected to the tube outside the body. It sits on the floor next to the patient's bed, and that creates a negative pressure and helps to expand that parietal and visceral pleura, again, expand the lung, and keeps those two membranes, again, with that negative pressure until they heal. So there's a number of reasons why someone's lung would collapse. I mentioned a few. Again, like I said, gunshot wounds, stabbings, fractured ribs breaking through that membrane, or surgery. Sometimes it can happen with just a tumor, a lung tumor, or it can happen from excess fluid around the lungs, or sometimes spontaneously. We find that young, tall, thin males are at risk for lung collapse just based on their anatomy. We're not quite sure what causes it. But anyway, moving on. So again, this process of breathing involves changing pressures. That's the biggest point here to make, is that we can see as the volume goes up in the lung with inhale, the pressure in the pleural space and within the lung goes down. And then as we exhale, volume goes down, and we can see that pressure in the alveoli inside the lung and in the pleural space increases. So volume and pressure are inversely related. They move in the opposite direction. So as we look at factors that affect how our lungs function, we have a couple of different things to think about. The lungs should be stretchy, which we call lung recoil or elasticity. So as the lungs are filling with air, they expand, and then as we exhale, they go back to their resting position, and that's elastic recoil. But the alveoli are lined with water droplets. We said that mucus has a high water content, and that helps to humidify the air and keep those alveoli moist. But because of that, water droplets have what we call surface tension, which means that they pull inward. Water droplets pull inward when they line a space. So that pulls inward on that space. And that could cause lung collapse if we had too much surface tension. But we have this special substance that's produced by cells that line the alveoli, and that substance is called surfactant. And what surfactant does is it breaks up the surface tension of water molecules. Think of surfactant kind of like soap breaks up oil droplets on a pan after maybe you've made some bacon. So surfactant helps to break the water droplets that would form inside the lungs and cause them to collapse. So this surfactant keeps our lungs expanded and prevents that collapse. So surfactant is actually released when you take a deep breath. So it's important that our patients are practicing deep breathing after surgery, because they can end up with some fluid in their lungs, and fluid causes more surface tension, which causes more water droplets, which causes the lungs to want to collapse. So deep breathing is really, really important for everybody to do, especially when you've been sitting for a long time studying for class. It's important to stop, sit up straight and do some deep breathing to keep your lungs expanded and have good gas exchange. Pleural pressure, we already talked about. That's the pressure in the fluid space between the parietal and visceral pleura. That always has a little pull. The visceral pleura is pulling inward, the parietal pleura is pulling outward because they're attached differently. Remember, the parietal's on the lung wall and the visceral pleura is on the the parietal pleura is on the body wall, the visceral pleura is on the lung, so they have a little bit of pull against one another in that fluid, which causes a negative pressure. And again, as long as that's negative, the lungs will stay expanded. Compliance is just a term that refers to the lungs' ability to move with the thoracic wall or the chest wall when we inhale. So that's, again, is also related to the lungs' ability to stretch. And then again, we said surface tension, that acts inward on the lung, which allows the lung to decrease in size when we exhale. So we want a little bit of surface tension. Surface tension is not all a bad thing. We just don't want too much, which would cause the lungs to collapse. So we have a nice balance between surfactant, keeping that surface tension under control, but the water having a little bit of surface tension, so after we take a deep breath, the lungs do go back to a resting position because of some surface tension pulling those alveoli into a smaller position because of the surface tension of the water molecules lining those alveoli. So we have different forces keeping them expanded, and then other forces that contribute to their reduction in size with exhale, and both have to have a nice balance. So again, we talked about compliance is important for allowing the lungs to expand. So if you have a stiff lung because of scarring due to just chronic exposure, like farmers who do a lot of hay baling and don't wear a mask can have fibrotic or stiff lungs. If there's a lot of fluid, that can cause the lungs not to want to stretch and move with the body wall. And respiratory distress syndrome is when there's chronic inflammation that causes the lungs not to move and stretch with the body wall. So people with reduced compliance have a hard time taking a deep breath. So again, when we look at the function of the lungs, we need those alveoli to be stretchy. We need them to open up and be filled with air, and then when we exhale, they need to reduce in size so we can get rid of the carbon dioxide from the blood. And it's all a balance of these pressures and volumes. So when you look at, for example, this diagram, it just shows how we have pressures in the fluid. We have pressure within the alveoli themselves. That's called intrapulmonary pressure. That's pressure within the alveoli. The alveoli are not shown here, but they are assumed to be here in the pink area. And then we have transpulmonary pressure, which is pressure across the wall of the alveoli and the pleural membranes. So when we look at atmospheric pressure, we assume at sea level that's about 760 millimeters of mercury, and that will be higher outside the body compared to inside the body just prior to inhalation. So once this rises and becomes higher than the pressure inside the lungs, which is intrapulmonary pressure, that's what forces air to move into the lungs. And then once atmospheric pressure and intrapulmonary pressure are equal, there's no more airflow. And then as the diaphragm moves up and the external intercostals relax and move the ribs in, that's going to decrease the volume, which is going to increase the pressure. And then intrapulmonary pressure will be higher in the alveoli compared to the atmospheric pressure, and that's going to cause air to flow out of the lungs. So we see this nice exchange here between the air and the alveoli just based on these two major pressures, which is the atmospheric pressure, the pressure of air outside the body, and intrapulmonary pressure, which is the pressure inside the alveoli. So intrapulmonary pressure is lower prior to inhalation, and it's higher prior to exhalation compared to the atmospheric pressure. So this is just a nice little model that's showing the size of the alveoli. It's much more complex than this, but it's reducing the alveoli into one little circle here. But you can just see when there's no air movement, the pressure outside the body is equal to the pressure in the alveoli. And then when we're inhaling, we can see that the pressure in the alveoli is lower than the pressure outside the body, which is the PB, which is barometric pressure in this case. And then again, when they're equal, that's when the breath stops. That's when the inhaling stops. And then as the lungs and the ribs move inward, that increases the pressure because the volume is decreased. Then we see increased pressure in the alveoli compared to the barometric pressure outside, and air flows out. So it's all about, again, these pressure and volume changes in the alveoli. There's two terms that you're going to see a lot of if you work with patients that have lung issues, and one is called a pleural effusion, and another is called a pneumothorax. These are not terms you need to know for our test, but it's worth mentioning because you might hear these terms in your clinical experiences. Pleural effusion means fluid in and around the lungs. So the lungs should be a hazy black. So we can see this patient's right lung, but we cannot see the left lung at all because it's full of fluid. So this is a bad sign. This person hopefully will get some treatments here to help them absorb that fluid. Sometimes we can pull the fluid off with a needle. It's called a thoracentesis, where we go into the thorax and we have a large needle and we pull fluid off. And I've had patients that we work with on our floor that they've pulled off a liter of fluid around a person's lungs. And boy, do they feel better after that. Pneumothorax is when those pleural membranes no longer have that negative pressure and that pleural space is not negative anymore. So the parietal and visceral pleura are no longer adhered to one another and the lungs collapse. So we can see this lung is collapsed because here we can see the hazy connective tissue of the lung showing up on this x-ray. But here there's nothing there because the lung is actually collapsed and is along the midline of the body here. So this is the lung that has collapsed. So this would require a chest tube to be inserted to create a negative pressure and eventually allow that lung to expand and fill this space again. This structure right here is the heart. So this is the heart here that you can see. And this is the lung, this hazy tissue. So this is called a chest x-ray, what we're looking at here, that we can use to look at the lung. Again, this one shows a chest x-ray full of fluid. And people can see tumors on there as well if someone has lung cancer. So we can test a lung function using a spirometer. So here we can see a person is taking a nice big inhale and then an exhale. And it's, when we look at it, it's roughly about the same. When we have a big inhale, you can exhale that same amount out. But quiet breathing is this little smaller graph here. This is called tidal volume. This is just quiet breathing. And when we have a big inhale, say if you were getting ready to blow up a balloon, you might take a big deep breath and then blow into that balloon. We have an inspiratory reserve volume, which is extra air that is reserved for big inhales. We also have an expiratory reserve volume, which is for big exhales. So let's say you're coughing or sneezing or laughing. We do have extra volume of exhale if necessary. But this little short up and down of about, what does it look like? About 500 milliliters, that's your quiet breathing, your tidal volume. But I'm not going to expect you to know these terms or these numbers. That's more for advanced A&P, but it's just worth mentioning that this is how we test lung function, is by looking at these numbers and seeing how they compare over time. So this just gives a little definition to each of those volumes, but again, I'm not going to hold you accountable for that because that's something we really go into detail in advanced A&P. The same thing with the capacities. These are all measurements that we look at if you were looking at patients with lung disease. We really want to look at their lung function over time. So gas exchange, we talked about that as a big piece of the respiratory system. And carbon dioxide and oxygen diffuse by simple diffusion from high concentration to low concentration. We find that these gases diffuse a little differently. For example, carbon dioxide diffuses more easily than oxygen based on its coefficient of diffusion, which is more of a chemistry concept and how gases diffuse across a membrane. We're not going to go into the details of that, but just know that the carbon dioxide crosses the membrane a little easier than oxygen does. And that's a good thing, because remember, we talked about carbon dioxide plays a big role in blood pH, and we don't want carbon dioxide to build up in our blood and cause our pH to drop and create an acidosis. So it's a good thing that carbon dioxide can diffuse so quickly and efficiently across our membranes. So when we look at again, how carbon dioxide and oxygen move across, they're a little different in how they are transported in the blood. And again, we said carbon dioxide moves a little more readily than oxygen does, but we find that carbon dioxide is highest in the tissues and oxygen is highest in the alveoli. So where we find the concentrations of these gases the highest in the body, oxygen is highest in concentration in the alveoli, and carbon dioxide is highest in the tissues, because that's where it's produced, is in the cells of the body during metabolism in the mitochondria. Remember that aerobic metabolism produces carbon dioxide, and then that's picked up and swept away by the blood and carried to the alveoli. And the oxygen comes from the outside air. Remember, the trees in our environment make oxygen, and then that comes in through inhalation into the alveoli, and then the blood carries it off to the tissues to serve the tissues and feed the tissues with oxygen. And remember, we can only live about 4 to 6 minutes without oxygen, and then the body cells quickly die. So it's so important, if you see anybody collapse, that you quickly come to their aid with CPR. So this is just another example. We can see lots of oxygen coming in to the blood from the alveoli. It's carried to the heart. The heart continues to pump it out to the tissues, and then the oxygen goes to the different body tissues and organs of the body. And these tissues have high amounts of carbon dioxide, which will diffuse out into the capillaries. It'll be returned to the veins, up to the right side of the heart, up to the pulmonary artery, to be blown off in our exhale from the alveoli. So it's this nice gas exchange working together with the cardiovascular system to transport those gases with the help of the heart to the different body tissues. So when we look at how carbon dioxide and oxygen is transported, most of oxygen is transported as hemoglobin. The rest is just dissolved in the plasma. So we have these nice hemoglobin molecules kind of as a school bus to preserve oxygen as kind of just a little reservoir that if breathing should stop, we do have 4 to 6 minutes for the oxygen that's carried on our hemoglobin to quickly dump off into the tissues and keep the body alive for 4 to 6 minutes. So that's why if we have low hemoglobin, for example, if someone's had surgery or they have a low number of red blood cells, they have what we call anemia, and that's going to cause poor oxygen delivery and transport, and people are going to feel short of breath and tired. So it's important that we get enough iron in our diet, because iron is a central part of our hemoglobin. It helps us to bind oxygen, so we need a good amount of iron in our diet to keep our hemoglobin levels healthy, and that's going to help with oxygen delivery. Carbon dioxide, on the other hand, is also bound to hemoglobin, but it's also found as these bicarbonate ions, which is written as HCO3-, which is something that is a part of carbonic acid. Remember, we talked about if you have a lot of carbon dioxide, that can drop your pH because carbon dioxide can be found in carbonic acid. And part of that carbonic acid can ionize into bicarbonate ion. So I'm not going to hold you accountable for the chemistry of how these things are transported, but you will hear more about this in advanced A&P, so it's worth mentioning here, but you won't be tested on the transport of carbon dioxide. And then some of that carbon dioxide is just dissolved in the plasma as well. So 3 different ways of transporting carbon dioxide. But when you look at how the respiratory rate is monitored and maintained, that is with the help of the medulla and the pons. So carbon dioxide is the major regulator of our respiratory rate. And again, the normal respiratory rate is 12 to 20 breaths per minute, and that's quiet breathing. That's when a person is relaxed. I've had patients on our floor have respiratory rates into the 40s when they're really struggling to breathe. They have to use extra muscles to try to bring air in, and they're feeling short of breath, so they're going to breathe faster, and that is not a healthy respiratory rate. We want to see that respiratory rate around 12 to 20 breaths a minute. And if it gets too slow, like when people are under the influence of heroin or alcohol in high amounts, that's dangerous as well because they're not breathing fast enough to feed their tissues with oxygen and to blow off that carbon dioxide, and that can be very dangerous and people can die from that. That's what Narcan is for. Narcan is what can rapidly raise the respiratory rate in people that have undergone a heroin overdose. We'll get more into that if you take advanced A&P. But anyway, the medulla oblongata and the pons work together to regulate our respiratory rate. So here's the pons, here's the medulla. You can see these nerves, the phrenic nerve going to the diaphragm, and those intercostal nerves serve the external intercostals, stimulating that contraction during the inhalation process. And then that stimulation turns off to allow those muscles to relax, and then we exhale. So exhaling is a passive process where all the muscles are relaxing, and inhalation is an active process where the nerves are stimulating the muscles to contract and to, again, increase the volume and drop the pressure inside the thoracic cavity. So this just describes how when we start to inhale, that's the medulla stimulating those muscles. And then as more and more of the neurons are activated, it stimulates those muscles to continue to contract. And then when the stretch receptors in the lungs stimulate that they are sending signals back to the pons stating that they are fully stretched, then that stimulates the nerves to no longer send action potentials to those muscles, and then the muscles relax. So the medulla is in charge of contracting the muscles, but the pons is what tells them to stop. So the pons is more like the regulator of the switching between inhalation and exhalation, but the medulla is what sends the active signals for contraction of those respiratory muscles. So again, carbon dioxide is so important to make sure we blow off carbon dioxide and that it's tightly regulated, because it can be very dangerous, that it actually determines the respiratory rate. So if carbon dioxide levels are raising, then the respiratory rate will increase because we need to blow off that extra carbon dioxide. So with exercise, for example, as we start exercising and moving our muscles and producing more carbon dioxide, that's going to cause an increase in the respiratory rate. And we also have a higher demand for oxygen as well. But carbon dioxide is the major regulator of our respiratory rate. So very, very important that we understand that. Because we have the help of hemoglobin, oxygen levels don't change that quickly to affect the respiratory rate. But carbon dioxide does, and that is something that we don't want to build up in the body. So it's tightly regulated, and we change our respiratory rate based on those carbon dioxide levels. So things that affect the respiratory rate, our brain can influence our respiratory rate. For example, your emotions. If you're feeling excited or scared or angry, that's going to increase the respiratory rate. If we have a low pH or a high CO2 level in the body, that's going to stimulate chemoreceptors in the medulla, and that's going to increase the respiratory rate in order to get rid of that excess CO2. We also have chemoreceptors in the carotid arteries and the aorta. If oxygen levels get really low, that's going to increase the respiratory rate. And then we also have stretch receptors in the lungs that we talked about. That when the lungs are stretched with a maximum inhale, that's going to actually de-stimulate, turn off the muscles for respiration to allow the lungs to relax. That prevents the lungs from becoming overly stretched. So these nice little stretch receptors actually protect the lungs from being overly stretched. And proprioceptors, which are just receptors that detect movement in the joints and muscles. As we move our joints and muscles, that's going to increase the respiratory rate. So the body's getting ready for exercise. So just moving your arms and legs, even if you're not working very hard, that's going to stimulate respiration via the medulla and the pons. And then touch, temperature, and pain. If you touch something that is painful or hot, you're going to increase the respiratory rate because it's just a protective mechanism, making sure we're getting enough oxygen if the body's under stress due to pain or heat. So all these things are factors that affect the respiratory rate. Again, 12 to 20 breaths per minute is the normal respiratory rate. So again, we talked about the stretch receptors. These are just stretch receptors in the lungs. And that is a major role of how babies breathe. We look at them as belly breathers, and as the lungs expand and stretch, their belly kind of pooches out, and then that tells the pons it's time to relax, and then they exhale. So babies don't have a real regular respiratory rate. They kind of breathe fast for a little bit, then they kind of slow down, and there's not really a regulation to it because they're just using the stretch reflex to primarily regulate breathing, where adults have a more regulated breathing and they're not belly breathers as much as infants are. But again, a person can be exercising really hard and they just can't take in enough oxygen because of that stretch receptors cause exhalation. Maybe when they don't want to exhale, but they're forced to exhale because those stretch receptors inhibit the respiratory process. So when we exercise, we're going to get a little bit of increased ventilation because of those proprioceptors as we get moving. So we start to feel short of breath right away with exercise, but it's not because we're out of shape. It's because we're simply moving. So everybody, even someone who's, an Ironman or a marathoner, they're still going to have that feeling of needing to breathe faster with exercise because of the movement of the limbs. But as we exercise more and more and we build up lactic acid from metabolism and heavier exercise, that drop in pH can sometimes increase the respiratory rate. But as we get more and more in better shape, we have less of that, and people find that they're not as out of breath when they've been exercising and training because their what we call the lactate threshold improves over time. So that's the benefit of training. But exercise is always going to cause an increase in the respiratory rate, just because we have a higher need for oxygen with working muscles. So as we age, the amount of exchangeable air decreases with age, and our ability to remove mucus from our airways decreases. It gets harder because the mucus is stickier and thicker. So we have less fluid, less water in the mucus, makes it stickier, and the muscles are weak. If we're not practicing deep breathing and people live a sedentary lifestyle, which a lot of people do as they get older, those weak muscles can't contract hard downward to cause a forceful exhale, because to exhale forcefully, we have to use accessory muscles. So we know that quiet breathing, the exhale, is a passive process, but if we want to cough or deep breathe, those take extra accessory muscles that we have to activate. And if people are sedentary and weak, they're not able to clear their airways, they're not able to cough, and that sets them up for pneumonia and respiratory infections. And that's a big reason why the elderly pass away from influenza and COVID and pneumonia, because they simply can't clear their airways because they have weak respiratory muscles. And then gas exchange is not as efficient because we tend to lose alveoli as we age. Smokers especially have broken down alveoli, and they have large holes in the lungs where the alveoli have been destroyed by cigarette smoke. So we have these areas in the lungs where there is no gas exchange. That's the residual volume and dead space. And where there is no gas exchange, then we can't deliver oxygen to the tissues as efficiently, and people feel short of breath and tired with activity. But with exercise, again, and not smoking, and making sure that we're practicing deep breathing, we can really maintain our lung function well into our 70s and 80s. But it just takes a little effort, and it means, staying away from cigarettes and quitting if a person does smoke, and getting some exercise just with some simple deep breathing. And that concludes our discussion of the respiratory system.